Good afternoon, everyone. This is Brian Robson, the Executive Clinical Director here at Healthcare Improvement Scotland. Welcome to the fourth in our series of QI Connect webinars. This series came from a request from our National Clinical Leads and our SPSP Fellows, our Scottish Patient Safety Programme Fellows, to connect frontline clinicians and others interested in quality improvement with international leaders in the field of improvement. They asked us to make the sessions short, accessible and recorded to allow access at a time that suited them. What I'd like to do now is hand you over to Lisa, who's going to explain to you a little bit more about WebEx, and then I will introduce the session itself. Over to you, Lisa.
Thanks, Brian. Okay, so just to get us started, a couple of housekeeping slides for anyone who's new to WebEx. I could ask you to not have side conversations. All of our lines are actually muted today, so you won't be able to hear everyone in the background. But if you want to chat at any point or ask any questions or get involved in discussion, please use the chat box that you'll see on the right-hand side. I'll go through that in a second. If you're having any technical difficulties logging in, or if you can't hear at any point, please use the phone number that you see on screen. Or if you want to message the event manager, which you should be able to see in the participants list, then just use the chat function for that. What you'll see on screen at the moment is on the right-hand side, on the top right-hand side of the screen, you should see a list of participants. What you'll be able to do is if you want to click on anybody's name at any point and send a message to that person, then there's a wee box in the bottom right-hand corner of your screen with a drop-down list. And if you click anybody's name, you can send a message to that person. I'd also ask, though, that if you could send messages to everyone, that way everyone can get involved in the discussion and keep the conversation open. Okay. Now, just a wee exercise to get us started, if I could ask everyone to click on the little blue arrow that they see on the top left-hand side of their screen, just under the File button. And now if you can click whereabout you're joining us from on the map. And apologies if you're joining us from out with Europe. The map wasn't big enough.
Rafe is in the North Sea. Pretty close. Great.
Okay. Thanks, everyone. I'll just pass back over to Brian.
Thanks very much, Lisa. Thanks very much for everyone that's joining. We'll tell you a bit more about yourselves just in a moment. Now, we've been joined by all of these organisations on this call, either immediately, synchronously as we speak just now, or asynchronously through the recording. And we're delighted to have this support from all across Scotland, all across the UK and wider afield. I would specifically like to just call out a particular thanks for joining us to Sue Hogg, who's the Director of Care at CHAS, Children's Hospice Association in Scotland. We're delighted to have you with us, Sue. Thanks very much for joining. And also to Shona Robinson, who is the Hospice Manager at the Marie Curie Cancer Care in Springburn in Glasgow. We're absolutely delighted that this webinar series is of interest to you and will help you in improving care for the patients and families which we serve. I'm delighted to hear you in your questions and in the chat box as we go through the session. We've talked about this before, but we're now reaching more than 38 countries through this webinar series, and it shows the international interest that we've got in listening to international leaders in the field of quality improvement. Also, importantly, it gives 38 countries, or people from 38 countries, the opportunity to discuss amongst themselves, to make connections, to ask questions, because, as we all know, we're all struggling with very similar issues and problems across the globe. So our numbers continue to grow, and we are establishing and supporting a truly international network. And as we called out at the last session, we're also delighted that ISQA have identified that this webinar series is worthy of an approved resource within ISQA's highly regarded fellowship program. And just to remind everyone that we are recording both the WebEx, we'll be recording the chat, and also recording any comments that folks have throughout the call, so that you can watch it again, or indeed share the link that Carmen will be sending out after the call. And of course, we are really keen that folks use social media, and thank you all very much for tweeting about the last event and indeed in the lead up to this event. So please tweet merrily if that's what you do with Twitter. Tweet merrily as we go through today's call. And just to put some pictures to the names, just a big thanks to Jennifer Graham, who's brought the series together, to Lisa, who's with us today, and also to Carmen Forrest, who's with us in the room here today. And I'm also absolutely delighted to welcome Fidelma Fitzpatrick. Fidelma is, amongst other things, she is a consultant microbiologist in Dublin, National Clinical Lead for Prevention of Healthcare-Associated Infection and Antimicrobial Resistance. But the big thing is that Fidelma is one of the Scottish Patient Safety Programme Fellows. We have a strong relationship with the Republic of Ireland, and Fidelma is one of the SPSP Fellows. We're delighted to have Fidelma posing the first question to our speaker today at the end of the session. Thanks very much for joining us, Fidelma. So, our speaker today is Frank Federico. Frank is no stranger at all to Scotland. He's been working with us on our safety and improvement work for probably pushing on the last 9 years. And we have some wonderful photographs of Frank from 9 years ago. I don't have any on the slides today, but I'm sure we can make them available to people. But Frank is the Executive Director for Strategic Partners at the Institute for Healthcare Improvement in Cambridge, Massachusetts. He has a lifetime of experience in patient safety, reliability, preventing surgical complications, and improving perinatal care. He is very well known for his work in medication safety and chairs the National Coordinating Council for Medication Error Reporting and Prevention, and Vice Chair of the Safety Advisory Group of the Joint Commission in the United States. Frank is very well known to many on the call, and certainly across Scotland and further afield for his groundbreaking work in the Patient Safety Officer Executive Training Programme and many other educational opportunities. Frank started off life as a pharmacist and has continued with his pharmacy background all the way through his career. I remember a time when Frank took me to the North End in Boston and pointed out the pharmacy where he had diligently worked as a jobbing pharmacist right at the front line in the North End in Boston. He also spoke really passionately about his time at Children's Hospital in Boston, and these are frontline experiences that Frank has never forgotten. So, Frank, welcome to the call. We're absolutely delighted to have you here, and looking forward to hearing about throwing the switch for change.
Brian, thank you, and welcome everyone to our call. It's so great to hear your voice again and think about all the good times we had when you were here, as well as the other work we've done in Scotland. Today's topic is change, and how do we encourage, support, and get the change that we want in an organization. I called it throwing the switch for change because a few weeks ago I got the opportunity to hear Dan Heath talk about his aspect of change. Some of you may know Dan Heath. He wrote the book Switch and also Making It Stick, two wonderful books that I think have messages for all of us in healthcare. And what I did is I adapted what Dan talked about into what I have seen in healthcare, my experience with coaching teams in hospitals and other healthcare settings, and to pull out the essentials that I think are extremely necessary for us and able to proceed. Next slide, please. And Lisa, if you want to give me the ball, I can also advance the slides. So just as a start, a point of reflection, I always ask people to stop and think about something that they've tried for themselves, whether it be in their personal lives or whether at work, some change that they've tried to make, and whether or not it was successful. It could be something at work. Maybe you try to implement a new program, a new form, a new opportunity to do something different. It might be something internally, such as you wanted to change your exercise regimen, you wanted to change your diet, you wanted to change the work balance that you had, work-life balance, anything at all. And just think about for a moment, if the implementation was successful, why do you think it was successful? And if it wasn't, what were some of the challenges then, the barriers that prevented it from being successful? And we'll come back again at the end to re-examine these questions for you and for others. Now, change is difficult for all. We know that because we know that in order to have improvement, we have to have some kind of change. If we keep doing the same thing over and over again, we're not going to get different results. If your automobile is designed to go at 50 kilometers per hour, you cannot force it to go to 100. Yet if it's designed to go 100, then you can't force it to go 200. It's always something that is relational to what's being done and what's been designed. Similarly, with your processes in healthcare, if you constantly have an infection rate of X per 1,000 patient days or X per opportunities, whatever it might be, and that number remains consistent, it's because your system was perfectly designed to have that kind of result. So in order to get improvement, we need some kind of change. Now, change means we have to have some improvement, some process improvement. And there are statistics out there that indicate that up to 70% of process improvement projects fail. Most of this comes from the lean literature. However, it's important for us to understand that not everything will succeed. However, why is it that we have such a high failure rate of when we're trying to do improvement projects? Some of the reasons that improvement projects fail include, and most importantly, an insufficient commitment from senior executives. And we'll spend a little bit more time talking about what that means. We need to ensure that there's engagement from the middle manager, that whenever the middle managers in an organization, and by middle managers I mean not people at the very top and not people who are at the front line of care, but people who have others who report to them. And these are the people that are so critical for improvement that unless they're engaged, it's not going to happen. The people at the point of care have to be engaged in the improvement. We continue to have discussions with organizations that have somebody do the work for them or do the work to them, as opposed to getting the actual people who do the work to tell you how to improve it, how to change it, because they're the ones who do the work every day and tell you how to make it. Another reason why a project might fail is that there's no clear line of sight between the work and the organizational objectives. That is, we've got a great project we want to work on, but if it doesn't align with what the organization's goals are, then how will we be able to support that project, and what value does it have if it's not going to support those objectives? The behavioral and cultural changes that are needed to support process change are so critical. And I'll talk a little bit about examples that we have heard from others and some leading people who are thinking in this field and what their attitude and their responses are. We need to have an improvement method, because without an improvement method, we're not going to be able to change. We wind up using training and education and expecting that that would change everything. But unless we have some improvement method, and the model for improvement is the model that the IHI has adopted, but there's Lean and Six Sigma, and they're all wonderful tools. However, each has a place, and each one requires somebody to have the skill to be able to use those. And the understanding that improvement is a way of life. It is not just a project. If you've improved just one aspect of care, that's all you've improved. In order to have overall improvement in an organization, you really need to be focusing on how do we create an environment where everybody sees improvement as an everyday task. Now, why do people resist change? Oftentimes, it's because people are being told they have to change, but don't really understand why the change is necessary. Many times people feel like we've been working this way for so long, why is it we have to change? All of a sudden our work is not valued anymore, and we tend to use things like reducing waste. And that might even be insulting for some folks because they've been working in a particular way for so long, and now we're telling them that the work they've been doing is wasteful. So I think the approach of getting them to understand why the change is necessary is going to be so critical. Change does mean new risks. You may be exposing someone to a different way of doing something that they may not be comfortable with, that they may feel the old way was getting us to an end point. Why do we have to change to a new way? Things may not go well, and so there's concern there. There's also the not invented here mentality. why should we adopt a change that was tried at a different organization? It isn't something that we developed, not something that we tried, then it really has no value or merit for what we do. People will have to learn new habits and patterns as they continue to try to think of different ways, new ways of doing things. However, there's also the fear that people have that if they're trying something new, they may not succeed. They may actually fail. And that is a fear that is real, even though that the plan is to help people understand and develop a process that fully meets and is able to provide the results that we want and people can actually accomplish the process. There's always the fear that trying to do something different may cause me to fail, and no one wants to fail. The other aspect that's important is the cultural aspect. That is, that work just doesn't fit how we do our work here. Our patients are special. And I came from a pediatric setting where I worked in the Boston area, and we were the premier pediatric hospital in the Boston area. And whenever we met with the other hospital leaders, we always said, well, we're different, we're pediatrics. Well, it's true that our patient population is somewhat different, but overall, the change processes, the kind of care that we wanted to deliver, the fact that some of the basics of human factors apply no matter what the patient population is important. But obviously, I could not put in a adult care process into the pediatric setting. I had to understand what does fit my culture, my context. And the last piece is that many times we don't realize the behavior that we are exhibiting, the modeling that we're doing. We don't fully appreciate the risk of what we're doing. And it could be something as simple as hand hygiene, although hand hygiene is not simple. But when people do not use appropriate hand hygiene, do they really understand the risk that a patient is being exposed to because they're not properly washing their hands? There is a white paper on the IHI website. It is free to download, and please visit the website and take advantage. And the paper is called Execution of Strategic Improvement Initiatives. And it really is a paper that discusses various aspects of improvement. And one aspect that I think is critical is the portfolio, the management of projects that an organization should handle. I'm going to explore more the cultural changes and the leadership, personal changes that have to happen, as well as every layer of the organization, not at leadership. However, this paper fully complements the work that we're talking about today. So why change? Paul Batalden is credited with this quote, "All systems are perfectly designed to get the results that they get." And if we truly want to improve our systems, we have to stop and examine what is it that we need to change, and how will we change that, and then how will we know that that change is an improvement, which is really the fundamental for the IHI model for improvement. But first off, what is improvement? And many times people think of improvement as we're using Lean, or we're using Six Sigma, or we're using the model for improvement. And in fact, improvement is not about using a set of tools. Maureen Bisognano, our Chief Executive Officer, and Tom Nolan from Associates in Process Improvement a few years ago did a survey of hospitals to determine what were some of the successful characteristics of hospitals that went year on year with reducing mortality and reducing harm. And what they found was very interesting, that when they first interviewed the hospitals, none of them introduced themselves as a lean hospital, or a hospital that uses Six Sigma, or a hospital that uses the model for improvement. They clearly understood that those are tools to help them to an end, but it wasn't what identified the organization. What identified the organization was their philosophy, their approach to improvement. Also, improvement is not setting up an improvement team and training people to do improvement. It is a necessary step, but in and of itself, that's not sufficient. Improvement is really a result. What is the end point of what we're trying to do? What are the things that we will change that will make the organization more effective in what we want to achieve? So improvement is not about a project. And oftentimes when we work with organizations, they find that they want to work on, for example, reducing pressure ulcers, and they think that's improvement. Well, that's improvement in one specific area. However, what happens is, unless that philosophy, that methodology is spread to other areas, it becomes a project that has been improved. However, is it sustainable? There, I'm sure, are many other opportunities for improvement, but there isn't the culture, the lifestyle, the opportunities for somebody to constantly be looking for ways to improve. So ultimately, when we think of improvement, we think of it as a way of life. Then individuals who work in an organization, who work in any healthcare setting, ought to always be thinking, my job is to do my job, and my job is always to find ways to improve how I do my job, because we can always find better ways. Tolstoy talks about change, and he says everyone thinks of changing the world, but no one thinks of changing himself. And this is important because as a leader in an organization, as a middle manager in an organization, or even as somebody on the front line, we can talk about change, but if we haven't changed our own habits, our own patterns, our own ways of doing work, we are just going to continue in the same environment and get the same results that we get, no matter how many improvement projects we put into place. So organizational change is inseparable from how an individual looks at him or herself. A group of folks at the McKinsey Quarterly looked at what are some of the changes that leadership needs to take on, and it's things like, how do I view change in the organization? How do I foster improvement? How do I train people? How do I coach people? How do I open doors and make the opportunity so that people can improve? All little things that the leader himself, the middle managers themselves, and the frontline people have to face. McKinsey goes on to say that half of all efforts to transform organizational performance fail because people don't act as role models, or people are totally resistant to change and defend the status quo to no end. It is the role of the leader to role model the behavior. So if leaders really want change, are they focusing on the change? Are they talking about the improvement? Are they making that a number one priority in the work that they do? Are they walking around and visiting the different areas and emphasizing the importance of the improvement efforts? Are middle managers supporting the frontline people who are doing the work, and are frontline people just coming to work every day and just getting their job done, or are they actually modeling the behavior of opportunity for improvement and changing? There will be some that will defend the status quo, again, for the many reasons I listed earlier. However, it is the job of leadership to work with those people and understand how to change their attitudes and their beliefs about the work that they're doing. The other aspect that's really important is that many companies fail because they look at the technical aspects of change. They're not looking at what the adaptive changes are. So they might say, teach me the model for improvement, teach me how to do measurement, and everything else will change. But what they forget is that change is associated with a lot of cultural and adaptive changes throughout the organization. The two examples I can give you come from two colleagues. One is Steve Spear. Steve Spear has written extensively about the Toyota production system and high-velocity organizations. And the other is from Dr. Gary Kaplan. Dr. Gary Kaplan is the chief executive of Virginia Mason and also chair of the board here at IHI. And Dr. Kaplan has continually sent people to study the Toyota production system. But in each case, when I asked them, why is it that people have gone to study Toyota, and yet very few organizations have been able to replicate that? And when I asked Dr. Kaplan, why is it so many people come to visit Virginia Mason, and yet very few hospitals have been able to replicate what Virginia Mason has done, they both tell me the same thing, is that when people come to study Toyota or Virginia Mason, they're looking for tools. They're looking for something to take away in their toolbox, but what they're forgetting is the cultural aspect that goes along with that. It's not just opening the toolbox and using the Toyota production system or the Virginia Mason production system. It's the things that are done by the leaders to ensure that there is a culture of improvement. It's the changes that are necessary in ensuring that the frontline staff see that line of sight between their work and the organizational goal. And similarly at Toyota, this is embedded in the work that they do. If you would talk to the Toyota people, they don't really tell you that they have a production system. They just do what they're supposed to do. Now, I mentioned that I started basing this work on Dan Heath. And Dan Heath talks about the rider and the elephant. The rider is the person or the part of our brain that provides the direction for where we need to go. The elephant is the rest of our brain. It's the resistance. It's the inertia of not wanting to change. And it is the responsibility of the rider to shape the path to change the environment, to change the behavior, to set it up in such a way that the elephant will then proceed in the direction that you want them to go. If you're interested in Dan Heath's work, there's plenty of information on the web as well as reading his book, Switch. But I'm taking what Dan talked about and I'm starting to translate it into healthcare so that we can better understand. For behaviors in shaping the path and setting the tone of an organization, it's important that leaders have an opportunity to close the gap between knowing what to do and what is actually done. Because many times the organization will tout that they're a front-facing organization, they're an organization that's focused on improvement, an organization that's focused on using methodologies for improvement, but when you dig more deeply, it may be happening in pockets, but it's not happening everywhere, or may not be happening at all. The other aspect about improvement is that oftentimes the solutions that we pick to problems might be more complicated than the problems we're trying to solve. And many of our solutions may be just band-aids to a broken system. So truly, one of the things that leadership has to do is to constantly guide the people who are doing the improvement work to dig deeper. And many times we use the same example that we use in root causes analysis. Ask the question 5 times, why? Because the more you keep asking why, the more you get to the real root of the problem. And the solution is going to look very different than it does for just one possible effect. So I had the opportunity to look at a number of root causes analysis for a Boston hospital, and in each one I would say that they did a great job of solving the problem. However, when I looked across all of them, the solution to the problem was very different because the latent condition existed at a very different point in care, and if they had fixed that one, none of the other events might have happened. So getting to the real root of the problem is important. And then ultimately, can leadership explain the manner and why it's important to change so that the people at the front line can understand the mission, vision, and purpose of the work? And I'm going to give you a couple of examples that we use at the Patient Safety Officer Training Program. This is a message that says our mission is to become the international leader in the space industry through maximum-centered team innovation and strategically targeted aerospace initiatives. Well, it's great. I don't know if anybody knows what that really means or what it is that we're trying to say here. Translated, this is what John F. Kennedy said. Our mission is to put a man on the moon and return him safely by the end of the decade. I think that if you were a frontline person working in an organization, this message is much clearer to you than the previous one. The previous one is fine, but it's really for the techies or if it's somebody who understands that vocabulary, but not the people at the front line. If we translate to healthcare, this is a generic message that I removed the name of the hospital, but it says, at University Hospital we are committed, and you can read this for yourself. It's quite lengthy. There's a lot there to remember, as opposed to if we were to switch this to say, we partner with patients and their loved ones to eliminate preventable harm, improve patient outcomes, and reduce waste in healthcare. Getting the right message out there is the first step in shaping the path, making sure that people understand what it is you're trying to achieve. Middle managers are also an important aspect of the care that we deliver. And again, by middle managers, I want to be sure that we are saying that not people at the C-suite office at the highest level, and they're not people who are delivering care directly, but they're the people who are responsible and have other people report to them. They are so necessary because they are the conduits. They're the people that need to translate what the senior leaders are saying in an organization to the people at the front line. What does it mean when we want to say we want to reduce mortality? That is a really big dot that you want to move. But what does it mean to somebody at the front line who has to deliver care? Well, the very translation is, let's reduce infections that contribute to mortality. Let's make sure we're delivering evidence-based care so that we're not harming patients. Let's be sure we have the appropriate protocols to respond to a deteriorating patient. When you translate that to the people at the front line, they can understand what that means. Some of you may be familiar with driver diagrams that we've used, and driver diagrams are an excellent way to help visualize what is that high-level mission on the left-hand side, the aims of the organization. What are the primary drivers, those concept changes that the middle managers now have to translate to the secondary drivers, which are the things that an organization, people at the front line can actually do and get that work done. Now, the problem with middle managers is that oftentimes middle managers are so busy running around and making sure that they're keeping the budgets intact, they're getting productivity, and in other words, in quote, get the laundry out, get the work done. So it's important that in working with middle managers, we also change what they do and emphasize that the importance improvement is such a vital part of what they do. And coaching teams is so critical to get them to do that work. What middle managers can do is facilitate that second-order problem solving. And by that I mean, let's figure out what the real root of the problem is. And let's create an environment where we can work together in a collaborative, we can do a real root cause analysis and get deep to understanding why we're having these problems, create space so that people can actually do some improvement work. All the staff are quite busy. They're caring for patients. We're filling their days up with all kinds of activities. Have we given them at all any space to stop and reflect and just give them an opportunity to step back a little bit and see what it is they can improve? And the last piece is that managers need to understand the change process. Many of the people who do daily work are not trained in how to improve. Many will respond by a training program. Many will respond by doing more education. Many respond by, we'll just audit and tell people when they do wrong, as opposed to understanding that an improvement or a change process requires a methodology, requires commitment, requires measurement, requires a change in culture, all the things that are necessary. The other thing that's important for middle managers in order to change is respect for people. Understand that people have something to contribute. Understand that oftentimes their ideas might not be the best ideas, but I say no idea is a bad idea until it's tested. So respect what people have to say. Engage them in the conversation. Develop teamwork. We know that teamwork is one of the major advantages when we run into human factors issues. That is, when people are tired, confused, when there's too much going on, a team can act in a way that supports each other and develops resilience. And ultimately, coach people. And by coaching, we mean providing constant advice, support, necessary to provide both the positive as well as correct the negatives. Model the behavior that you want people to have, because if the manager models the behavior, then you're likely that the frontline staff will follow that behavior as well. You also need some experts in improvement if you really want to throw the switch on improvement. We call them improvement advisors. The fellows, are those people who are experts in improvement. And part of your job is not to do the work for the frontline team. That's their job. But your job is to help them, to help identify where the opportunities for improvement, to help plan what it would be like for us to improve the processes in our ward, in our work area, in our hospital as a whole, in any work environment. Help to execute the improvement project throughout the organization, because what works well on one ward is only going to work well on that one ward. But how do you then spread those bright spots, the effective program that you have, to all other parts of the organization? That requires planning, and that's not necessarily what the people who are on one ward can do. The expert is responsible for helping deliver successful results. That is, if the project's not working, if the work is not achieving the results that we want, then what are the changes we need to make within the work itself? Maybe we've chosen the wrong intervention. Maybe we've chosen the wrong people to work at that intervention. And of course, as I said, spread throughout the entire system. Local champions are also important. Anywhere we've gone in organizations, having a local champion is somebody that provides to continually provide support for that work, provides direction towards the organizational goals, continually works to remove roadblocks, and works with the middle managers. Now, who could be a local champion? It could be a physician. It could be a nurse. It could be a pharmacist. It could be any healthcare provider. But it needs to be someone who is well respected. It needs to be someone who understands how the system works. And it also needs to be someone who is engaged and can be part of it. It's not just a title. This is work. This requires somebody to be actively engaged in making improvement. The people delivering care are also so important. They're the ones who really can tell you where the problems are and what needs to change. Within a ward, we oftentimes tell stories about everything that's gone bad in patient care. And I've actually taken the other approach that when I bring together a group, I ask them to tell me a story about a patient where everything went well Everything was organized, and the patient got the care they wanted, the care they needed, and they were discharged from the hospital, or they got the appropriate care in the ambulatory setting, or they got the appropriate care in a long-term care facility, wherever it may be. We call those bright spots, and I'm stealing that from Dan Heath. What are the good things that happened? Because if it happened once, that's an opportunity to learn. What happened during that process that made it work, that we now can replicate and use it in other ways? The people at the front line have to understand that improvement is more than vigilance training and hard work. It requires change. The focus of the people on the front line should be on processes. Ultimately, of course, we want to improve outcomes, but you can't improve outcomes until you change the processes. So those people should always be charged with ensure that the bundles are implemented correctly, ensure that we're delivering evidence-based care with the appropriate processes, because if we're doing that correctly, then the outcome should follow. If the outcomes don't follow, then it may be the process is incorrect, or we're doing something else incorrectly that we need to follow. And most importantly, if you want to improve, you have to measure locally and you have to measure often. Having someone else do the measurement for you is not going to be good enough. You really have to, at the end of the day, determine how many patients today got the care that we wanted. Because if the patients did not get the care that we wanted, and it's not statistically significant, it's not supposed to be. But if you have, for example, the IHI recommends look at 5 charts today. Of those 5 patients who were admitted for the ward, did they all get their pressure ulcer assessment? Because if of the 5 patients, 3 did not get it, or 2 did not get it, then your process doesn't work. It doesn't matter that you collect more information. But that kind of information gets the people at the front line concerned. They want to make things better. They want to be part of the change. You also need opinion leaders. You cannot do any of this work until you find who the opinion leaders are. These are people who are influential. They may not necessarily be the administrative leaders. They may not necessarily be the folks who everybody looks up to in some fashion. But these are the people who, whatever they say, somebody else will say, well, if Brian says that's something that we should be doing, then I think we should consider that, and we should do it. Everett Rogers talks about the different aspects of change that are necessary, and I translated some of them, and I'm going to come back to them again in a few slides, that in order for people to accept change, it needs to be testable. That is, people need to be able to test it for themselves. And I ask you within your own lives, look at something that you've done that's different. You might have chosen a new phone. You might have chosen a new type of food that you wanted to do. The first thing is you always want to test it. Let me see what it feels like. Let me see how it works. I need to determine that for myself. It needs to be better than what we're doing today, because if you're asking me to add steps to my process, you're asking me to use a checklist, I need to understand why that is better than what we're doing today. Is it getting me the results? Does it help me do my job better? I need to be able to see that it does result in improvement, because if it doesn't result in improvement, why are we doing it? Is it just to satisfy some obligation that somebody has created, or are we really learning from it? So one of the areas that I think has been a real challenge for some organization is the surgical checklist. In one organization, they were at 100% compliance with the checklist, but when I dug a little bit deeper, it was with the tick boxes in the checklist, not the purpose of the checklist. They really didn't understand why the checklist was important. They didn't see that the checklist might result in improvement. And so that was something that we needed to work on to help them understand. And lastly, it must fit our culture. You cannot just impose something on another hospital, another ward, without fully appreciating that each one of those is its own little microculture that you need to deal with. Changing mindsets. People need a purpose to believe in. People need to know why they're coming to work, and it links to why we get into any discipline, any career that we get into. We need to have the skills required for that change. We need to have consistent role models, because if the leaders of the organization, if the middle managers are not consistent, then the behavior that they exhibit will be the behavior that every other person in the organization will then follow up. And we need to have reinforcement systems. And the reinforcement systems are for the positive behavior, but they're also systems that address the negative behavior and don't reinforce that, but actually change the behavior. Rogers again goes on to the adoption curve, and the reason I included this is no matter who you are or where you are, at some point you are at a different point on the adoption curve. You may be an innovator in the very beginning, and yet you may be a late majority person later on with something else. So it's important that as you begin your work and you think about improvement, think about where you will find people on this curve, and then appeal to that, because the innovators are the ones who are always looking for the innovation and are always at the cutting edge, but get bored very quickly. They look for something new. The early adopters are the people who will take this on and get the bright spots and become your ambassadors to teach others, and then the early majority, etc. There will always be the traditionalists, and you have to deal with those people in a very different way than you would with anybody else on that curve. So how do we improve in healthcare? Well, the first question is, what is broken and how do we fix it? And maybe what we ought to do is change that discussion to what is working well and how do we do more of it? What are the bright spots that we have? What are some of the big problems that we have in healthcare? Well, maybe we ought to change that, solve the big problems with a series of small solutions. Our reliable design methodology does exactly that. It tells you start small. Don't try to solve everything at once because the problem is quite big. But if you start doing something small and you do it over time, you are more likely to get the improvement that you want. Again, visiting Rogers, these are his terms, and what I did is I translated them, so I'm providing them for you. I thought the most important piece, again, here is advantage as well as simplicity and complexity. When we talk about solving a problem, we oftentimes make the solution so complex that it's impossible to be sure that people will actually be able to execute on that. If you want to improve, don't offer too many solutions. Get the people at the front line to really tell you what's going on. Provide guidance about the new direction. Dan Heath calls that setting the path. Where is it that we want to be? What is it that we want to accomplish? Think that solutions may not necessarily have to be big system solutions, but small solutions might get you to a better point. Provide positive emotions, that is, joy in work. Many times we refer to the example from the National Aeronautics and Space Administration where a group of visitors found a person who was sweeping the floor and asked him, well, what's your job here? And the person said, my job is to help put a man on the moon. Within your organizations, what is it that people come to work to do? Remind them that in healthcare, we are there to provide good care for patients. We're there to help patients get better. And no matter what you do within the organization, your role is to always help us achieve that goal. And focus on what has already been conquered and say, look at how well we've done in this area. And now let's figure out how to do it better in other areas. So let's go back to the reflection. Think of a change that you wanted to implement, and then think through. Did I know why we were making the change? Or did I explain to the people I was working with why they needed to make the change? Did they understand what the process changes should be? Did they understand what our endpoint was? And if it didn't work, was it because we didn't have the appropriate engagement from leadership, or personally from yourself, from middle managers? Or did we use techniques that maybe just weren't the kind of techniques that were going to be helpful to us to improve? They were just training and education, necessary but not sufficient. So with that, I'd like to open it for questions. By the way, my email address is on this slide. Please feel free, if you have any questions or comments, to write to me directly. Love to hear from you.
Frank, thank you so much. That was an amazing run-through, and we're absolutely inundated with questions, in fact, so we may ping some of them off to you by email afterwards. And let's cut from Frank in Boston over to Fidelma in sunny Dublin. Fidelma.
Well, greetings from sunny Dublin, and thank you for asking me to ask the first question. I feel a lot of pressure, but Frank, fantastic presentation. Thank you very much. Really good point about middle managers, because they're absolutely squeezed from both ends, and I really like what you say about making improvement a way of life rather than a project. And I have two probably very basic questions. The first relates to a little bit of sustainability, but sustainability of people like me. So I'm a simple person that's done the fellowship. I've got all these great ideas, and I come back to my hospital and I want to make change. And you try and you try and you try, but sometimes you're human and you get burnt out because people say, oh, here we go, we've heard it all before. So is there any top tips for maybe lone nuts like myself to keep yourself going? So that's the first question. And the second question is, given that all culture is local, and I absolutely appreciate that, you can't just plonk bundles into my ward or my ICU and expect them to work, is there any general themes or trends from, let's say, organisations like Virginia Mason in terms of what things leaders do or how they connect to the front line?
Sure, great questions. Thank you. So tips on keeping you going. It is, and I think that a couple of things, and I've gone through it myself, and I've experienced many times the lows of trying to change an organization. I guess a couple of things. One is remember that you have a skill set that you've developed, you have some experience that you've developed, and the people that you're working with may not either understand or have those same skills. So it's always important that you work with people at the very basic and understand, do they understand what we're trying to accomplish, et cetera, because otherwise you can lose them simply with your language. We oftentimes tell our fellows who come to IHI, when you get back to your home base, don't have the wet dog syndrome where you shake and you spray everybody with all the knowledge that you have and nobody understands what you're trying to accomplish. So first step is look for ways that you can help say the message to those people in a way that they can understand it. Secondly, look for allies. Look for people who are interested in improvement, people that you can talk to, people that you can spend some time with and say, I'm really stuck on this project. I can't get it going. How do I get people engaged? And ultimately, remember to celebrate the good things you've done. And if you do that and you engage the frontline people with those kinds of celebrations, then I think that that's really an important aspect that energizes you as well as others. And sometimes, the energy has to come with leave your place of work for a conference. Go someplace else where there are like-minded people that you can work with. Now, the whole fellowship that you have there is your own network of people that should be supporting each other when things don't go well, that you could pick up the phone and call someone and say, let's have a chat here. I really need somebody to give me some energy. I find that that's very helpful to me. As for leadership engaging with people at the front line, one of the things that we've been looking at and that I think has been something that organizations, and you may be doing this, is we talked about walk-rounds. And walk-rounds have been something that have been implemented now in many, many places around the world where the senior leaders go visit a ward to understand what's going on. We've seen another example develop in the Mayo system, and others have been doing it as well, where they have a learning board. And what the learning board is an opportunity or a place where the teams are posting the tests of change, their run charts around their process improvement. It's an opportunity to display in one area the improvement activities on the ward. Now, it's not everything, but it's what we're working on today. In Denmark, I saw a wonderful example of a ward that said, that basically had a calendar of things they were working on. So they would maybe say working on pressure ulcers, and they would show their progress on pressure ulcers. They would show the test of change, but they hadn't done anything on central lines, for example. But on that calendar, they had a timeline that said, we will begin central line work in July, just so that it gave them a sense of managing the project. And what leaders have, and we're recommending that they do, is meet with those people at those boards and let the people at the front line explain to you what they're doing. And be ready to ask questions about, so tell me about your progress. Tell me why you've done that small test of change. But also advise if the test is too big, why don't we take a step back? That's too big. Or what are some of the barriers that you're facing, because I can maybe help solve them. And many leaders are afraid that if they say that, they're going to wind up with every single barrier the team has. But the reality is that's what the leader should be facilitating, to say, so what can you do about solving that problem? And here's a problem that's bigger than you are that really belongs with the leadership. That's something that I'll take on. We found that it really engages the team. So it's one technique that we found has been quite successful.
Thank you.
Thanks very much, Fidelma, and thanks, Frank. Frank, just a question here from Scott Oliver, who's a clinical teaching fellow in NHS Lanarkshire. So obviously very interested in training up our junior staff. And he asks that he says that there are many junior clinicians who are very enthusiastic about quality improvement, but perhaps lack the insight into specific organisational goals, what things they should be aiming at. And he says, is it better for leadership to provide practical guidance for junior staff or is it better to rely on the coal-face clinicians to detect the issues they might benefit from for quality improvement investigation?
So, Brian, I think it's a little bit of a balance. I think one of the things that I am concerned about when I go to organizations that have juniors working on a number of projects is that they're working on a number of projects and there is no plan to ensure that any improvement becomes sustainable, or that even if the project isn't finished within the time frame that they have, there's somebody that it's handed off to continue it. So my coaching for a number of large organizations, and I'm working with one that's 8-hospital system now, is it's great to have the juniors work on something, but let's align it with what we're trying to accomplish. If, in fact, what we're trying to accomplish is reduction in infections, is there something in the area of infection prevention that they can work on? Because it'll benefit them to learn how to do improvement, and at the same time, it'll align with the organizational goal. It's that line of sight. I worry about organizations that have too many projects going on but don't have a good system to manage them all and to see them all to completion and implementation. A hospital system in the south of the United States, when we were working with the frontline managers, they were telling us, we have so many projects going on, nothing is ever completed, and we just get loaded on with more projects. So you don't want to waste will if somebody has a good idea they want to work on. However, at the same time, I just caution you not to have too many things going on at the same time that don't align with the organizational goals.
Great. Thanks for that, Frank. I hope that helps with Scott's dilemma. I'm sure shared by many. Got a question here from Leslie White, who heads up the mental health and dementia in our Quest team, the improvement team based in Scottish Government. She says that encouraging people to be self-reflective and insightful into modelling the behaviours they expect to see in others, aligned with the vision, is a complex area. Would Frank have any top tips for this?
Yes. Starting as simple as if we wanted to talk about hand hygiene, for example, if the most senior person, if the senior consultant or the administrator or the middle manager constantly exhibits that kind of behavior, then you will notice that others will do that as well. I will give you an example that at one of the Boston hospitals, I saw a very high rate of hand hygiene. They have all the hand gels in multiple places, and it's so much so that I watch family members use the hand hygiene as well without any instructions from anybody. So when we talk about modeling behavior, what are the things that we expect? What are the things that we want them to do? So the behavior from the very high leadership level is if the leaderships talk about safety, but they never model the importance of safety, they never walk around and ask people about their concerns about safety. On any agenda, leadership agenda, safety is not a top item, then clearly that's not modeling the behavior we want. We also want to ensure that we're not reinforcing bad behavior. And part of what leaders can do is when they find that disruptive behavior, to deal with it. And there are many ways to deal with disruptive behavior, and Team Steps offers a whole bunch of ways to do that, and I'm sure you have many as well. But it's got to be, what is it we expect our people to do? And think of, if you're a parent, what model of behavior do you want that you want your children to adopt? It's the same kind of thing. It's really not, I don't see it as taking a lot other than thinking through. If I want to be a leader who is respectful to everybody on staff, then as I walk down the hall, I should demonstrate that and be respectful to everybody on staff. I just visited a hospital where we could not walk down the hall without the chief nursing officer greeting everybody almost on a first-name basis. And this is a large institution. I don't expect you to know everybody's name, but at least greeting them is so important. I'm not sure, Brian, if that answers the question, but I just think of everyday life, you model behavior every way. Why not take it into healthcare?
Yeah, no, I think that will probably hit the button for Leslie. Thanks for that, Frank. One final question. Frank, this is from Linda McKechnie from NHS Dumfries and Galloways. Linda's a Service Development Manager down in Dumfries and Galloways. How do we, A, convince staff that they don't always need permission to make changes or test things out, and B, get seniors to allow people not to ask permission?
Great question. We are working in a large hospital system now that when we started talking about go back and test a change, what we got back from the frontline staff is, well, that's policy and we can't change policy or we can't make any changes. It is a slow process. Clearly, one has to understand that change in an organization that is so structured, where today the culture is you have to ask permission before you do something, will require change. That's the culture that has to change. It has to be the middle manager and the leadership that says, you know, Brian, Linda, you know this isn't going well. Do you have any ideas how we could do it better? Do you want to try something out on a small scale? And then support that. And remember, test small. Don't try to get them to solve the entire problem, but just try something small just to learn how to do it. And I think that leadership has to say it's okay. It's okay to run small tests to change. Now, large organizations are fearful of that because they're fearful of all of the work that they've done to provide standardized processes, and then they say, we're going to let them do all kinds of changes and destroy everything that we put in place. No, that's not the intent. The intent is there are certain things that are standardizable throughout the organization and should be. But on the other hand, there are certain processes that just cannot be standardized everywhere. The policy should be standardized. So an example I use is identifiers for patients. Well, the policy is every patient is identified using 2 or 3 identifiers, whatever you use, but how you do it in pediatrics and how you do it in adults and how you do it in a trauma unit, how you do it in the intensive care unit are all going to be different. And you have to allow for that kind of variation because otherwise you think you have a great policy, but nobody's following it. Nobody can adhere to it because the procedures weren't designed by the people at the front line who actually have to do the work. So give permission for that one test of change. Let the senior leaders know it's okay if you need to change something to make it better. But it does take time. Even in this organization we're working with, we got a lot of excitement, but there's still fear. Do I really need to ask permission to do that? And that's where you have to work with the middle managers to say, let go a little bit and let them test something. You still have some control, but unless you let the people test something new, you're going to have the same problems you continue to have today.
Frank, wonderful. Thank you so much. Now listen, we've come to the end of our time with Frank today. I'd like to thank everyone that contributed to the questions, to Jackie McCallum, to Paul Arbuckle, to Rachel Bruce, to Linda, to Leslie, Scott Oliver, Jennifer Graham, and all the others on the call, Margaret McCann, Francis Rooney, etc. You've really made this a really highly interactive session. And Frank, a big thank you to you. It's been absolutely wonderful. The time has flown as ever. We've got some outstanding questions, and with your generosity, Frank, I'd like to just put them to you after the call, if that's okay.
Wonderful. I look forward to it, and thank you for the opportunity, and I wish all well.
Wonderful, Frank. And you'll recognize this guy. So Rocco Pella is our next speaker. Frank, a very good friend of Frank's. Rocco is the founding director of the Learning and Diffusion Group at the Center for Medicare and Medicaid, the CMMI. So President Obama's innovation lab, if you like, set up by Don Berwick. And Rocco was an IHI fellow and spent a lot of time with Frank. So Rocco has kindly agreed to talk to us on the 18th of June. He's really excited to do that. The title of the talk, Whole Patient Measures, Making the Patient the Fundamental Unit of Analysis. That sounds pretty dry, but you will be delighted to hear that, in fact, that was the title of Rocco's award-winning article, the Impact Article of the Year for the Journal of Healthcare Quality in the US for 2013. So impressive stuff. We're all trying to measure harm. Rocco's found a way of doing that and predicting it, and you'll find his talk highly engaging. So, Frank, thank you very much again. We look forward to spending time with Rocco. Big thank you to Carmen Forrest, who's with us today and has coordinated the whole event. To Lisa Birch, who's been keeping the technology right. To Sheena from British Telecom, who's done a sterling job in bringing us together. And to Jennifer Graham, who's not with us today, but whose inspiration started this whole series. So, thank you all very much. Have a great day, and please share the recording when Carmen sends it out. Thanks very much, folks.